Hi, everybody. I'm Dr. Carmen Puliafito. I'm here today with Dr. Jack Wells, who is with Palmetto Retina in South Carolina. Jack, welcome to Retina Synthesis.
Carmen, thank you so much for inviting me. I'm happy to be here.
Jack's been a real pioneer in clinical trials of diabetic retinopathy, and recently at the 2022 angiogenesis meeting, presented the 2-year results from the RHINE and YOSEMITE studies on Faricimab. Can you tell us a little bit about what Faricimab is and why it should be of interest to physicians treating macular diseases?
Yeah, sure. So obviously, all the currently available agents to treat diabetic retinopathy, diabetic macular edema, have been centered on inhibition of VEGF. And there was a lot of preclinical evidence that the angiopoietin pathways might be important to look at in terms of promoting vascular stability. So we know that in the same conditions that VEGF is upregulated, there's upregulation of angiopoietin 2, which tends to destabilize the endothelium and lead to vascular instability and leakage. And so this molecule, Faricimab, is really the first bispecific antibody in ophthalmology, where there is an arm that binds VEGF and an arm that binds angiopoietin 2. And it seems that the combination of those, inhibiting both of those, leads to greater stability of the diabetic vasculature and longer duration of treatment effect than VEGF inhibition alone.
So at the angiogenesis, you presented the 2-year results of YOSEMITE and RHINE. So why don't you tell us a little bit about these trials and how they were designed and what the questions they asked were?
Yeah. So YOSEMITE and RHINE were 2 very large phase 3 trials. That's really the largest trials of DME that I'm aware of. And they both looked at treatment of center-involved diabetic macular edema with Faricimab in 2 different dosing schedules versus aflibercept at its regular, usual labeled dosing schedule. So eligible patients had to have center-involved DME with a OCT central subfield thickness greater than 325 microns and visual acuity of 2040 to 2320. And eyes were equally randomized to either Faricimab given in 6 monthly loading doses and then every 8 weeks thereafter through 2 years, or Faricimab given in 4 monthly loading doses and then according to what was termed a personalized treatment interval, which was essentially a treat and extend strategy through 2 years. And those 2 arms were then compared to aflibercept given in 5 monthly loading doses and then every 8 weeks through 2 years, which is basically according to the label on the drug. And the primary endpoint of the study was the corrected visual acuity at 1 year. And they averaged that over weeks 48, 52, and 56. So it was an average visual acuity over those 3 visits. And that was used as the mean change from baseline. And then the patients were again followed and treated through 2 years. So the study end was at 2 years. So that was basically the design. The treat and extend group, they were given 4 monthly doses from baseline, and then monthly dosing was continued until they achieved a central subfield thickness of less than 325 microns. And then at that point, treatment was given at increasing intervals. If the patients were stable, if they were improving, they were continued at 4-week dosing. Once they were stable, they could be extended in 4-week increments up to 16 weeks. And if at any point they were worsening, then their intervals could be reduced by 4 to 8 weeks. So that was how that treat and extend strategy was designed.
So what were the results?
So importantly, so the primary endpoint was the mean change in visual acuity. And then in both studies across all 3 arms, roughly at 1 year, all groups gained about 11 letters. So there was no, faricimab was non-inferior. They were basically equal vision results. And that mean change in vision was sustained through 2 years. So that was good to see. The main thing, though, was in the faricimab treat and extend group, the personalized treatment interval group. At 1 year, 50% of those eyes were on a 16-week dosing schedule, and another 20% were on a 12-week dosing schedule. So 70% of the eyes in that treat and extend arm were on a 12-week or longer dosing schedule. So obviously for the angiogenesis presentation, it was the first presentation of the 2-year results. Everybody was very interested to see whether that durability signal would be sustained. And in fact, it was not only sustained, it was increased. At 2 years, 60 to 65% of the faricimab treat and extend arm were on a Q16-week dosing schedule, and another 15 to 20% were on 12 weeks. So almost 80% of eyes in that arm were on a 12-week or longer dosing schedule at 2 years. And also interestingly, it was that if an eye, 80% of the eyes that achieved a Q12 or Q-week dosing schedule at 1 year continued to have that dosing schedule through 2 years. So there wasn't a lot of going back and forth. There was, sustained durability seen from year 1 to year 2.
So, so most eyes were able to be extended out.
Yes, in that arm. And again, they were being compared to Q8-week dosing for the other faricimab arm and the aflibercept arm. And those 2 arms obviously were not extended past 8 weeks. But when you look at the anatomic changes, the faricimab arms also were, you saw higher proportions of eyes treated with faricimab in both arms that had absence of DME, which was defined as a central subfield thickness of less than 325 microns. So over 80% of eyes in the faricimab arms at 1 and at 2 years had absence of DME. The aflibercept arms was slightly lower at 70% roughly. And also when you looked at intraretinal fluid on OCT, more faricimab treated eyes had absence of intraretinal fluid compared to the aflibercept group. And that was true whether it was on the Q8-week faricimab dosing or the treat and extend dosing. So reduced dosing did not seem to be associated with worse anatomic outcomes or visual outcomes. And in the second year, the median number of injections in the faricimab treat and extend group was 3, and it was 5 in the other 2 groups. So there was about treatment in that treat and extend group in year 2.
So you've been involved in lead author on Protocol T that really, I think it's fair to say, revolutionized our approach to diabetic macular edema. So how will you incorporate these findings into everyday management of patients with diabetic macular edema?
Well, obviously, anytime you see fairly convincing results from large phase 3 studies like this, you're certainly going to want to incorporate it into your practice. I think initially, we have a lot of patients we know from Protocol T that chronic persistent edema is very common, and we have a lot of patients that are continuing to come on a monthly basis for a long period of time to try to manage their DME. And so those patients in particular that are, requiring frequent monthly injections on aflibercept or ranibizumab, I would certainly try to switch those patients over to faricimab. And, once I see what kind of effect I'm getting in those kind of eyes in my clinic, then I'd be, if I'm getting a good response, then I'm going to be very likely to start using it first line as well.
So Faricimab fit in with aflibercept and bevacizumab.
So, well, in protocol T, obviously bevacizumab was equivalent to ranibizumab and aflibercept in eyes with better vision at baseline. And so I know a lot of people would argue that, you could start with bevacizumab. I've always been troubled that even in those eyes with good visual acuity in protocol T that were treated with bevacizumab and had a good vision outcome, the anatomy was never as good. Through 2 years, the reduction in central subfield thickness in the bevacizumab group was 50% less than ranibizumab or aflibercept. So I'm not a big, I don't utilize bevacizumab much in the treatment of diabetic macular edema for that reason alone. I mean, we'd like to see the edema go away, right? And yeah, it's not going to go away as frequently with bevacizumab.
So what are the mean number of injections that patients currently in the network recommendations? What was the recommended mean number of injections in year 1?
Yeah, so if you followed the DRCR treatment algorithm, 9 to 10 injections were given in all 3 groups in year 1 and 5 to 6 in year 2. So there was about 15 to 16 injections on average given through 2 years. So in this faricimab, PTI arm, there were only 3 given in the second year. I think in the first year, I actually don't recall exactly, but I think it was 7 in the first year in the faricimab treat and extend group. So that would be, a reduction of a third, 10 injections in 2 years versus 15 to 16.
So the recommended starting dose is 4 monthly injections for PTI?
Yes, right. And then continuing monthly treatment until the central subfield thickness is less than 325 microns. I failed to mention it, but in that PTI arm, only 7% of eyes were still getting 4 weekly injections at year 1. So very few numbers were requiring, continued monthly therapy in the first year.
So this is a treatment burden reducer.
I think so. I mean, obviously the vision outcomes were the same. The anatomic outcomes seem to be better than with aflibercept. And so I think that's clearly the benefit here with faricimab is that you can reduce the treatment burden.
Have you started using it yet?
We haven't gotten it in our inventory yet. It's just been a few weeks. I guess we're a little slow to get it, but I'm told we're going to have some in the first week of March.
Yeah, that sounds great. So Jack, this is a great discussion. You're, like I said, you're very involved with the network. What's the next big question that we need to answer about diabetic macular edema?
Well, that's a really good question. I think that there are trials being considered right now looking at other delivery systems, oral agents, which previously oral agents have always been complicated by systemic side effects. I don't know what the next target is going to be, but in prevention, obviously, if we could prevent DME, that would be ideal. So the network has expanded its focus. It's changed its name to the DRCR Retina Network. And lately, a lot of energy has been looking at other retinal diseases. So we'll see what happens.
Well, listen, this is a delightful discussion, and thanks for your leadership, and thanks for your wonderful presentation.
Well, thank you. I really appreciate your invitation to discuss it.
Okay, bye-bye.
Bye-bye.